Hello everyone. Thanks for joining us for today's webinar on tackling the emotional challenges of type 1 diabetes. This webinar is supported by the Sanofi Lexicon Alliance. The presentation is educational in nature and contains no promotional or product information. Continuing education credit is not available for this activity. If you would like to ask a question during the presentation, please feel free to type it into the Q&A box on your screen, and we'll answer as many questions as we can during the Q&A session at the end. Our speaker today is Gary Shiner. Gary is a certified diabetes educator, master's level exercise physiologist, and a person with type 1 diabetes since 1985. He's the owner and clinical director of Integrated Diabetes Services, a private practice dedicated to helping children and adults with insulin-dependent diabetes. Gary has authored 6 books, including Think Like a Pancreas, and lectures internationally on a wide array of topics in diabetes care. In 2014, Gary was named the AADE Diabetes Educator of the Year. So without further ado, I will turn it over to Gary.
Thank you very much, Megan. I appreciate the kind introduction. Interestingly, I was surprised when I was asked to put this presentation together because I'm not a mental health expert by trade. This is a little bit outside of my usual comfort zone. But I realize that all of us involved in diabetes care and education have to become experts in a lot of different fields in a lot of different areas. I'm guessing many of you on the call today are not mental health experts either, so we're kind of learning together. What we're going to cover over the next 45 minutes or so, we'll start out discussing some of the specific challenges that are faced by people living with type 1 diabetes and some of the things that might predispose them to having challenges to their mental health. We'll focus on some of the specific mental health conditions that are highly associated with type 1 diabetes. And along the way, we'll be discussing the role that we as diabetes care and education specialists play in helping patients handle these emotional challenges. So let's start out looking at some of the specific challenges that people living with type 1 diabetes have to face. And there are a lot of daily demands. I remember a few years ago, one of the companies in the Silicon Valley that has a lot of type 1s working at the company actually did a kind of an internal study to count the number of points during the course of the day where they were thinking about something related to their blood sugar control. And they averaged something like 45 sort of thought points every day. That's a lot of times to have to be thinking about something. And there's a lot of daily demands that are placed on people living with type 1. They have to calculate insulin doses, and those are usually based on blood sugar levels and carb counts. So carb counting is another part of the daily rituals. They have to manage and maintain a steady flow of supplies. They have to monitor their glucose, either through continuous glucose monitoring or through finger stick checks. There's multiple self-care practices involved in just keeping oneself healthy. That may not be directly related to blood sugar control, but things like foot inspections and getting the exercise in and so on. Plus all of the exams and lab work that needs to be implemented throughout the year. So there's a lot of demands placed on people who are living with type 1 diabetes. And now let's consider specifically some of the sources of stress that people with type 1 have to face. One is the inconsistency of glucose levels. And this is actually, I learned, one of the hallmarks of clinical depression is when people are exposed to situations repeatedly where the outcome varies for no apparent reason. And people with diabetes will often mention, I did the same thing 2 days in a row and I get completely different results. And that's part of daily life with type 1 diabetes, is that unpredictable nature of glucose levels. There are certainly financial stressors involved, having to afford and maintain supplies and access proper health care. And it's getting worse over time as people are enrolling in these high deductible plans and high copay plans where financial barriers are there constantly. there is this constant threat of complications in the back of everyone's mind who has type 1. Granted, we can't prevent them 100%. There's certain things we can do to reduce our risks, but nevertheless, there is always that threat in the background. The risk of complications is multifactorial, and even those who manage their glucose levels meticulously are still at an increased risk. So that threat is constantly there. And for those who already have existing complications, there's the stress that can cause and the challenges that it poses to just living day in and day out, whether it involves impaired vision, limited kidney function, nerve disorders, or macrovascular disease. There's constant pressure surrounding food intake, not only to make healthy food choices, but to quantify the impact that food's going to have on glucose levels so that insulin can be matched to it. And also, the pressure to maintain a healthy weight and to pay attention to the timing of meals and snacks. Finding time to engage in regular physical activity can be a source of stress. You got to remember, people with type 1 have lives like everyone else and all the responsibilities associated with that. And you throw these additional diabetes-related responsibilities on top of it, and the time pressure can be substantial. And from a social standpoint, there are multiple stigmas and prejudices out there that people with type 1 have to face almost every day. Now, some of that is food-related or taking injections or taking insulin, etc. One of the funniest but most appropriate shirts I think I ever saw was at a JDRF conference. Someone was wearing a shirt that said, "Yes, I can eat that." I thought that spoke volumes about having to answer questions and overcome a lot of the misunderstandings that are out there related to living with diabetes. We also have multiple physiologic issues in place that can predispose people to mental health challenges. Most people with diabetes take multiple medications, and the interaction between those medications can have negative repercussions from a mental health standpoint. Chronic hyperglycemia and acute hyperglycemia can affect moods, and it can affect biochemical balances throughout the body, as can hypoglycemia, both in the short term and the long term, in terms of its effects on cognitive function and behaviors. So we have a lot of responsibilities that people with type 1 have to face. We have a lot of stressors that are in place, and also physiologic changes that all predispose people with type 1 to increased mental health issues. So here's the first of a handful of quiz questions for you, and you have an opportunity to post your answer. Question is, which of the following is not more common in people with type 1 diabetes? Is it depression, schizophrenia, distress/burnout, or disordered eating? Which is not more common in people with type 1 diabetes? I'll give you a few moments to post your response. Well, maybe we do have a lot of mental health experts out in this audience, because 96% of you answered that correctly. The answer is schizophrenia is no more common in people with diabetes than in people without. So this is a list of some of the mental and emotional health conditions that are much more common in the type 1 diabetes population. It includes diabetes distress, commonly called diabetes burnout, as well as depression, anxiety disorders. And there are a few specific anxiety disorders that are specific to the diabetes population, and those being anxieties over high or low blood sugars, as well as needle phobias. And then disordered eating patterns, including binge eating disorders, anorexia, and a condition we call diabulimia. And we'll get into more detail about that in a few moments. I pulled this quote from an AADE practice paper. I felt it really summarized things quite well for us. Diabetes care and education specialists need to be equipped with resources that complement the psychosocial management for people with diabetes. Now, the grammar may not be perfect here, but I think you get the idea. All of us in the diabetes care practice and business need to be able to recognize and assist patients who are challenged by mental health conditions. And let's start out talking about diabetes distress, also called diabetes burnout. This is a condition where an individual focuses undue stress and time and energy on diabetes and the tasks required to manage it. It's kind of an overwhelming feeling. It can affect the person with diabetes as well as caregivers who may be carrying out many of the day-to-day tasks on behalf of the patient. It can be exacerbated by stress or anxiety, and it can also be exacerbated by complications of diabetes. We'll talk about depression in a moment, but the presence of diabetes complications really increases the risk of all of these mental health problems exponentially. And the problem with this diabetes distress, besides causing turmoil for the patient, is it does make it very difficult for them to maintain proper self-care behaviors, and their hemoglobin A1C and now, with time in range being a more prominent metric, those tend to suffer. The prevalence is quite extensive. It's estimated to be present in about 1 out of 3 adolescents and adults with type 1. And as I mentioned, it can also affect parents and caregivers. And the outcomes can be the same. Even if the caregiver is experiencing the burnout, the patient suffers just the same. Some of the symptoms that we commonly see in patients with who are experiencing burnout, one is that they may sort of almost sabotage their own diabetes care in terms of their food intake, where they'll eat more and eat the types of foods that they know are going to place an undue stressor on their blood sugar management. They may not be upfront or honest with their healthcare providers, family members, or friends regarding blood sugar levels. Many of them may go extended periods of time without checking their glucose or wearing their sensor or looking at their sensor. And some of them will also just calculate doses off the top of their head. We call the winging it or the WAG method for calculating insulin, rather than going to the trouble of actually calculating the doses properly. Now, the role that we play in patients who may be experiencing burnout, there is an assessment tool that can be used called the Problem Areas in Diabetes Questionnaire, also called PAID. We recommend routinely administering this. It's not a bad idea to plug this in on an annual basis just to see if somebody is experiencing burnout, because it does change over time. Just because somebody's fine today doesn't mean they're going to be fine a year from now. You may want to administer this a little more frequently if patients are not meeting their goals, and also in patients who have existing complications from their diabetes. In terms of the treatment, things that we can do is, one is identify barriers to their care. And if there are significant barriers, we may be able to work to overcome some of them. There may also be educational gaps. One that I find commonly is patients thinking that their glucose levels have to be within a very narrow range almost all the time. And it can be very burdensome to attempt to do that, and a lot of disappointment associated with it. So educating patients, for example, on acceptable target ranges and allowable glucose levels after meals as opposed to before can be very useful. Simplifying the management plan can also go a long way. If the patient is having to perform too many tasks throughout the day, you may be able to condense or eliminate some that aren't absolutely essential. Breaking down self-care into small, manageable chunks, things that are achievable to the patient, can be very helpful. There can be a sense of overwhelming if there are so many things that have to get done, and they may just throw the throw it all in and say, I'm not going to do any of it. But if you just have a few manageable things at a time, make baby steps with that. And certainly referral to a behavioral health specialist for further assessment if some of these types of interventions are not working. These are some good resources that can be turned over to patients who may be experiencing burnout. There's a couple of videos online by some prominent social media experts in type 1 diabetes, Carrie Sparling and Ginger Vieira. And there's also a couple of very good books, Dr. Bill Polanski's Diabetes Burnout book, and a book on dealing with diabetes burnout by Ginger Vieira. Here's a second question for you. True or false? Depression tends to be both more severe and more common in people with type 1 diabetes. Is it more severe and more common in people with type 1? You know, that word "and" is there to possibly deceive you. Okay. Well, the word "and" was there to trick you. This is a true statement. Patients with diabetes do have more severe and more common episodes of depression. In fact, depression is present in about 1 out of 4 adults and children with type 1 diabetes. Personally, I've lived with depression for a good 25 years now, so this is something I've learned about firsthand. It's also associated with an increased risk for other psychosocial difficulties, so kind of like autoimmune conditions. Someone who has depression is likely to suffer from other mental health challenges as well. And depression is both longer in duration and more persistent in people with type 1 diabetes compared to those without diabetes. In youth, it's present in a large proportion as well. About 1 out of 4 are at very high risk. Almost 1 out of 5, 1 out of 4 experience depressive symptoms, and almost 1 out of 10 experience thoughts of self-harm. Symptoms of depression may be common to many of you, but it's still worth running through these. Feeling down, feeling sad or hopeless on a regular basis. You know, everyone can have momentary situations where they feel down, but if it's occurring on a regular basis, that's very different. Feelings of worthlessness or feeling shameful about one's life. Feeling pessimistic on a regular basis. Having less interest in normally enjoyable activities. Overall, having less energy and wanting to sleep either excessive amounts or hardly at all. The inability to escape negative thoughts is another kind of trademark of depression. And certainly any thoughts of self-harm could be a sign of depression. This is a slide I kind of picked off of another website. I felt it really summarized nicely the two-way relationship, sort of the negative feedback loop that we see between diabetes and depression. Having diabetes lends one to depression because of the stressors, the challenges involved in managing it day in and day out. Potential tension between patients and their providers, the fatigue that can be present, and some of the difficulty in making dietary changes and sticking to a diet plan. But then depression feeds into diabetes and can worsen glucose control by altering hormone levels, causing somebody to have less energy and possibly being less apt to exercise, causing anxiety or nervousness, and certainly thoughts of self-harm. And it can also cause changes in appetite. So in many ways, diabetes feeds into depression, and depression also feeds into diabetes. There are very simple questions that you can ask in a patient encounter, asking them about how they just feel about their own care, about how they feel about having diabetes, how they feel about their general day-to-day life. These are the types of questions that can be asked just when somebody comes in and sits down and you're trying to get things warmed up and get them talking a little bit. Ask them if there are things that they're excited about. If they tell you, no, there's really nothing that makes me happy, nothing I'm excited about, that could be a warning sign. Ask if they're able to do what they want to do on a day-to-day basis. Find out about their sleeping patterns and ask about their mood, whether they are feeling down for extended periods of time. There are a multitude of validated inventories that can be used to assess the potential for depression. The PHQ-9, the Beck, the Zung. There's a specific children's depression inventory, a strengths and difficulties questionnaire, and also a suicide screening questionnaire. Some of these are accessible online, and the scoring is fairly easy to calculate. So these are types of things that you can certainly use within your practice. Treatment is highly individualized. Antidepressant medications are often used, but they're not a requirement. Many people benefit from cognitive and behavioral therapies, but referral to a mental health counselor is a prerogative here. If somebody scores positive on a depression inventory or exhibits multiple symptoms, this is the kind of thing that needs to be both diagnosed and handled and managed by somebody who's truly qualified. There are depression resources online. There's a suicide prevention hotline that you can share the number for, and there are 2 online presences, the Behavioral Diabetes Institute and the Center for Diabetes and Mental Health. Let's turn our attention to anxiety disorders now. Adults with type 1 have elevated levels of generalized anxiety disorder, as well as a number of forms of anxiety that are specific to people with diabetes, those being anxiety over hyperglycemia, anxiety over hypoglycemia, and needle phobias. And children with type 1 are also subject to this. They're at a 20% higher risk than kids without diabetes. Those with anxiety disorders will usually exhibit very inconsistent self-management behavior patterns. We may see intervals where they are doing the things that are asked of them and managing well, and then they may have intervals where they completely fall off the boat. It can lead to a decrease in overall quality of life and certainly a worsening of glucose control. Let's look at the hypo and hyper anxieties. And all of you have probably seen patients who experience these types of things. Almost 1 out of 3 people with type 1 exhibit some symptomatology of hypoglycemia anxiety. And 1 out of 4 will overeat dramatically when their glucose is falling, not specifically when it's low, but when it's headed down. So it's a time where they may need to keep an eye on things or maybe have a small snack, but they go to the other extreme and send their blood sugar very, very high. It's been found that 1 out of 3 people with type 1 diabetes lacks the confidence to drive due to fear of low blood sugar. Some have irrational fears of elevated glucose levels as well, and may drive their blood sugar levels low on a frequent basis. I have a number of patients who exhibit this, and it's sometimes more challenging dealing with this than with those who fear the lows. They run themselves in a low range almost continuously because in their mind, any high blood sugar is harmful and dangerous. It may go back to their original diagnosis, but this is where some repeated bouts of education about the long-term complications and what really leads to them can be useful. People who have hypo and hyper anxieties tend to become very proficient at managing their glucose within a very narrow range, but they tend to use counterproductive avoidance strategies. So those with the hypoanxiety will tend to run a little high all the time. Those with hyperanxiety will run a little low all the time. So they tend to throw themselves into the opposite extremes. The treatment for these, there's a number of different approaches that can be used, and I wouldn't hesitate again to refer people to a qualified mental health provider for assistance with this. For those with hypoanxieties, low blood sugar anxiety, blood glucose awareness training can be helpful. And this is a process whereby patients learn how to identify early either physical or mental symptoms that their glucose is falling. Use of a continuous glucose monitor is a very effective tool for helping reduce hypoglycemia anxieties. And I want to go back a slide. You'll notice up at the top, I didn't point this out before, we have 31% of type 1s who score high for hypoanxieties, but only 21% of those using CGM. Now, the CGMs provide a very nice early warning system for low blood sugar, and you can set those low alerts pretty conservatively. You don't have to wait till the glucose is in the 70 or even 80 range. You can have alerts go off in the 90 or 100 range. That will often give a patient the confidence to manage their glucose more effectively. Making progressive adjustments to targets and acceptable ranges is also beneficial. So somebody who has, let's say, an anxiety of high blood sugar may be running their glucose in the 50 to 100 range all the time. We don't have to shift them to a normal glucose range all at once. Maybe we shift them to accepting a range of 60 to 120 or 70 to 140. We don't have to get to a standard target or acceptable range right away. We can do that in small steps. Make sure any educational gaps have been filled. Patients need to understand the multifactorial nature of complications, that blood sugar control is only a small part of what leads to long-term complications. And there are no guarantees when the glucose is well controlled that it's going to solve or prevent complications entirely. They should also be educated on the short-term and long-term effects of hypoglycemia. For those who do run themselves low consistently, they need to understand that it can cause damage to gray matter, that it can cause rebound highs, it can cause extra eating and weight gain, and it can affect the symptomatology when the next low rolls around. Needle phobias are another specialized form of an anxiety disorder, and this can easily cause fainting or vomiting. I probably should have found a different picture because, and I found this to be the case, this is much more common in men than it is in women. I think women are generally more tolerant of painful situations than men are, and we often see this happen with men, and it applies to injections with syringes, with pens, also insertion of infusion sites for insulin pump users, and potentially insertion of sensors for those using CGM. So understanding if there is a source of the fear, and then practicing techniques to minimize the pain. One strategy I've found to help in a number of cases is I'll have a patient sit down, try to relax them as much as I can, have them visualize their happy place, and I keep a recording of a song on my computer. It's a song by a group called the Eagles called Peaceful Easy Feeling. I found it to be the most calming, relaxing song, and after they've heard that song for 3 minutes and they've thought about their happy place, oftentimes they are able to tackle a challenge like an injection. Referral for behavioral therapy, though, is often needed in patients with severe needle phobia, so don't hesitate to do that if you're not able to make inroads. As far as general screening for anxiety disorders, ask patients how they feel about their health in general, about their day-to-day life. Ask if there are things that they're not able to do. I have one patient who for the longest time, didn't go out to eat at any restaurant because he was afraid he wouldn't be able to count the carbs correctly. And being able to teach him that type of a skill and explain to him that the exact count isn't necessary can really make a difference. Ask about sleeping patterns, ask what their coping strategies are now when they do feel anxious, and how often they feel anxious. A couple of questionnaires are in place. There's a screening for childhood anxiety, and there's something called an SDQ, the Strengths and Difficulties Questionnaire, which is fairly easy to implement in an office setting. Treatment for anxiety disorders typically involves behavioral therapy and what's called mindfulness training. But again, referral to a qualified mental health provider is necessary for properly handling these situations in those cases. I think we got one more quiz question for you. Eating disorders in people with type 1 diabetes can almost always be handled by the diabetes care team, can sometimes be handled by the diabetes care team, or should always be referred for specialized treatment. What do you think? Some of you see that word always and think, that couldn't be right. But kind of like the last question that I asked, don't be fooled by that word always. It's still true. So C is the correct answer, and 60% of you did answer that correctly, so good job on that. Patients with type 1 who are suffering from an eating disorder should always be referred for specialized treatment. Disordered eating is a brain-based disorder, and it involves food obsession in some form. There are often body image concerns, abnormal body image concerns. It often includes obsessive exercise behaviors, or we'll talk about other behaviors involved in bulimic situations. And it may include some diabetes-related behaviors that are going to interfere with daily living and quality of life. So the risk is quite high. Women with type 1 diabetes are 2.5 times more likely than women in general to suffer from a disordered eating pattern. 31% of women have reported intentional insulin restriction, and that's something that we refer to as diabulimia. During puberty, the rate of disordered eating is as high as 50%. And unfortunately, the people with type 1 who have a disordered eating pattern are about 3 times more likely to develop microvascular complications. Binge eating is also a common issue in type 1 diabetes, and this involves consuming copiously large amounts of food in one sitting. And this often goes above and beyond typical hunger-based feeding. This is eating beyond the point of satisfying one's hunger. Anorexia nervosa is also more common in type 1, and this involves just general restriction of nutrition. In some cases, it's done to avoid taking insulin, and we usually see patients with very low body weight, and unfortunately, the mortality rate is quite high for people who develop anorexia nervosa. Bulimia involves either normal or binge eating, followed by a compensatory behavior designed to eliminate calories from the body. And this may be done through oral purging, through insulin omission, use of laxatives, or excessive exercise. And diabulimia is a kind of a subcategory of bulimia. And this involves the intentional and inappropriate reduction or omission of insulin in order to facilitate weight loss. So blood sugar control goes out the window when this happens. A person will eat their either normal amounts of food or more than usual and take very little insulin. Typically, they're only taking enough insulin to meet base metabolic needs, so enough to prevent ketoacidosis in most cases. And the glucose control becomes extremely poor, and this can facilitate other mental health problems such as depression. Some of the warning signs we see in patients with an eating disorder, we'll see extremely high A1Cs, not in every case, but in some cases. Avoidance or anxiety over being weighed. People who are exercising more than seems healthy. Extreme levels of stress. And interestingly, we may also see frequent severe low blood sugars And this may be due to taking insulin and then being afraid to eat or pulling back on normal food intake. We have several screenings that can be used. The SEED screening assesses thoughts on body image and feelings about quality of life. It doesn't really capture anything related to insulin misuse, though. The MSCA-5 is a fairly quick assessment tool to capture thoughts and behaviors related to disordered eating or body image. And there is one specific to diabetes called the DEPS and the DEPS-R, and these will assess thoughts about weight loss, food, and diabetes management collectively. You have to be a bit careful about who you administer this to, though, because it could be a suggestive type of a test. And in those, it can cause a bit of negative feedback from patients who feel that, well, you're just assuming I have an eating disorder because I'm doing this. But in general, I think if you are in question about whether someone has an eating disorder, I would go ahead and administer it. From our standpoint, addressing gaps in self-management education is still important, emphasizing that glucose control has far-reaching effects that are far more important than weight issues. Look at aspects of a person's diabetes plan that may be contributing to that eating disorder. Perhaps there's too much emphasis being placed on counting this and that in one's diet. But anyone suspected or diagnosed having an eating disorder should always be referred for behavioral therapy to work on that in a professional way. These are some additional resources that patients can be referred to. There is a 24-hour diabulimia helpline, and that provides information both for people with diabetes and their providers, so you can call on this as well. There's a couple of good online support groups and a few websites. The We Are Diabetes formed several years ago, and it's a very influential group of people in the social media space that provide excellent support. There's a diabetics with eating disorders site in the UK and another in New Zealand. And a couple of excellent books have been put out. Injecting Hope, about recovering from an eating disorder, and one specifically on diabulimia. So I think this is a very good checklist for us to all utilize. We should always refer patients to a mental health provider if any of these situations are present. If diabetes self-care remains impaired even after a good self-management education program has been implemented, if the patient has the tools and the skills but the results are still not happening, there's a good chance that there is an underlying mental health issue that needs to be resolved. Anyone who scores positive on a validated screening tool for any of the conditions that we discussed, if you suspect or observe symptoms of an eating disorder or insulin manipulation, any positive screening for anxiety, or if a patient states anxiety over elevated or low glucose levels. If you see repeated hospitalizations for ketoacidosis or severe low blood sugar, anyone with a screening for cognitive impairment is going to benefit from working with a mental health specialist and perhaps just learning adaptive types of techniques, or if any form of serious mental health is suspected. Another very good quote, and this came from AADE in Practice earlier this year: a good fit between the mental health provider and individual with diabetes is an important component of a productive, helpful experience. In other words, not every mental health professional is ideally suited for every patient. I'm sure you can relate to this, having dealt with your own healthcare providers. It's important to find a good match. So let's take a look at who the key players are, who the key providers are in the mental health space. Social workers typically have a master's level degree, and they are very good at assessing overall patient needs and helping to connect them with necessary resources. LCSWs are licensed clinical social workers who do what a social worker does, but also can provide psychotherapy in individual or group settings. A clinical psychologist usually has a PhD, and they're going to evaluate mental health concerns. They can perform assessments and deliver psychotherapy. Neuropsychologists usually are also PhD doctorate level that can assess mental health conditions, a variety of conditions. They can evaluate cognitive abilities. They can implement rehabilitation and provide adaptation counseling. Psychiatrists are medical doctors who pretty much can do what everyone else does, but the use of psychotropic meds is sort of that's their belly laugh. That's their area of specialty. So if medical intervention is going to be needed, working with a psychiatrist is generally going to be necessary. And the fact is, just about everyone can benefit from some form of mental health therapy, even if it's just talk therapy. Patients who are doing well, patients who are doing poorly. It is a good thing to refer patients for, regardless of the situation, because I think everybody can benefit from this. And one resource I do want to mention is the ADA's Mental Health Provider Directory, and this is sortable by geography. So do check this out and make it a bookmark on your favorite search engine. And utilize it. If you don't have one already, build a good, strong list of mental health providers in your local area. If necessary, meet with them or speak with them and find out what their areas of expertise are. And it's a very valuable weapon to have in your tool chest in the management of patients. So just to kind of put all this together, as diabetes care and education specialists, our role in handling mental health challenges, we should be providing individualized and comprehensive education for our patients. A knowledgeable patient is much less likely to develop mental health challenges. Be cognizant of the symptoms of the various mental health conditions, and be prepared to implement some very preliminary basic screenings. But I think one of the keys is have a cadre of good mental health providers that you can refer patients to, as well as having access to other resources that you can turn over to patients. I want to thank you very much for taking an interest in this topic. It is something that is near and dear to me, living with it personally. And we'll open things up to any questions that you might have. And I'll turn things back over to Megan.
Great. Thank you so much, Gary. So we are going to open it up for questions. So if you have one that you'd like to ask Gary, you can type it into the Q&A box. We've already got a few questions in, so we'll just get started here. So the first question says, with the increased use of CGM, is diet bulimia decreasing? And then she clarifies, especially with teens.
Well, I don't know about any statistics related to that. I do have some patients in my practice who use CGM and are still challenged with restrictive eating and or restricting their own insulin. I think it gets to a point where they kind of ignore the impact that it has on their blood sugar. One thing it can do, though, is having the CGM there, and if the data is being shared with other people, is it might make others cognizant of the fact that there may be a problem. And that's the first step in helping that person get the help and assistance that they need. I think CGM use is beneficial in many, many ways. And my gut tells me that it can be beneficial in early detection and treatment of a variety of eating disorders.
Great, thank you. Next, what are the cognitive impairment education tools that you use in your practice?
Well, when a patient, we have tests that we use to evaluate health literacy and health numeracy. I don't remember the names of them offhand. So besides hands-on evaluations of patients' abilities to monitor glucose, to use a pump, use an app, or whatever they're utilizing, we also try to evaluate their reading ability and their number crunching skills. That's really the limit of what we're doing from a cognitive standpoint.
Great, thank you. The next one says, we are currently working with a 19-year-old male with type 1. His A1C is 14%. He misses mealtime insulin about 2 to 3 days a week and sometimes skips basal insulin. He refuses a pump. Not testing, but recently got him on CGM, which reports shows scans once a day. He refuses mental health referral. He does have insurance. Any thoughts on how to reach this patient?
Well, since he's 19 years old, it can be a little more challenging. That's an age group, that young adult just getting into independent living phase, where diabetes often takes a back seat to many other things. For somebody like that, involving their girlfriend and or boyfriend, involving a close friend or two may be beneficial. But I think one of the key things is trying to implement small changes. Obviously with an A1C of 14 is a lot of stuff that's not happening. So making small changes, small manageable changes that he can accomplish would certainly be helpful. But as the saying goes, you can lead a horse to water, but you can't make him drink. It would probably benefit a great deal from some talk therapy with a counselor of some kind. But if he's unwilling to go, there's only so much you can do.
Great, thank you. Next question. Are you saying that depression may have a cause from type 1 based on the level of their blood sugar? And would this apply for type 2 as well?
Yeah, there is some evidence that there are some physiochemical changes in patients with chronic hyperglycemia. We already know that at the cellular level, at the nerve level, sorbitol levels are elevated surrounding the cell. Neurotransmitters play a significant role in the development of many forms of depression. And when you're interfering with the biomechanics between cells and concentrations change, osmotic gradients change, there is most likely a role that elevated glucose is playing physiologically in the development of depression.
Okay, thank you, Gary. Next, we have a teen using CGM and InPen for diabetes management, but still checks fingerstick 12 plus times a day. He's had therapy for OCD with not much improvement. How can you help a child with type 1 that is doing so many of these poor management practices, guessing at carbs, chasing blood sugars down into lows often? His fear of blood sugar over 200 creates a cycle to chase down the stacking insulin. He's pulled off the pump because it was dangerous. What are your thoughts on this?
Well, it's a great question. You have to begin by considering who is managing the diabetes. Is it the child or is it the parents? And try to narrow down where that source of anxiety is coming from. It sounds to me like a case of hyperglycemia anxiety, but there may be some hypoglycemia anxiety built in there as well. There also appears to be some distrust in the CGM if somebody is still monitoring their glucose 12 times a day and is wearing a CGM at the same time. But that's an opportune situation to involve a good mental health provider in evaluating that kind of a case.
Great, thank you. Gary, do you know of any studies to prove that CGMs lower the rate of depression? I personally have had type 1 for 43 years, and the CGM has made a huge difference in my control and has reduced many of the unknowns that can leave us feeling powerless.
Well, I can relate to the person who submitted that question because I often feel the same way. Most people who start using a CGM are able to improve their glucose control, which can lessen the symptoms and risk of depression. I think there's also some benefit in just being, knowing what your glucose is at any given time. And the not knowing sometimes can be a source of some anxiety. There's eliminating a stressor of having to do finger sticks throughout the day makes one's life a little bit easier, which can alleviate depression issues. But I do have to warn, there are people with anxiety disorders who become obsessive about looking at their CGM too often. The alarms and alerts can be bothersome to them, so we have to be careful about utilizing CGM in people who are susceptible to those types of anxieties. I do agree. I think it does help lessen depressive type symptoms by using a CGM regularly.
Great, thanks, Gary. And we have one last question here, and it says, what is the best way to approach the person who needs help?
I think honesty is the best policy, and transparency can go a long way. No hidden agendas. And I think if you come at it from a standpoint of you care about the person and you want to do what's in their best interest and want them to feel good, they're more likely to take it in a constructive way. I also stress with patients who are on the fence about getting help from a mental health professional that it's not something they have to commit to for the rest of their life. I tell them, talk to this person one time and see what it's like. It's kind of like the way I talk people into trying an insulin pump who have never used one before. They say, no, I don't want to wear something the rest of my life. I tell them, well, don't. Just try it for a few weeks, and if you don't like it, go back on injections. With mental health care, those providers know how to communicate effectively with people, and the patient's likely to stick with it. It's just getting them in for that initial visit, getting them over that hurdle. So let them know that it's something just to try out, maybe to just sample it and see what they think about it.
Wonderful. We have no more questions. So, Gary, I want to thank you for being here today and presenting this information and providing these resources. And we thank you all for attending today's webinar. We ask that you please take a few minutes to complete the evaluation survey in order to provide us with your feedback so we can continue to improve our offerings. You can find the link to the survey on the first page of your participant handouts. This webinar was recorded and will be posted on our website, diabeteseducator.org, under the Education dropdown, and also at the link that you see on your screen. Thank you all. This concludes today's presentation.